the gold standard, everything that you need to know about preemptive kidney transplants. I'm very happy to have you here today for our webinar. We have Janet Wright, who is a preemptive kidney transplant recipient, who's going to tell us a little bit about her journey. And we also have the kidney recipient coordinator, Michael Garrels, who's going to talk to us about the process and what you need to know about this journey. To get us started, I am going to ask Janet to introduce herself and tell us a little bit more about her journey.
Hi, everybody. I'm glad that you made the webinar. So in our family, we have a family tree of polycystic kidney disease. And a lot of people don't understand that it's a non-curable disease. And what happens is over time, because of genetic mutations, the kidney becomes very cystic and enlarged. So here is just an example of a normal kidney and one that has polycystic kidney disease. I was diagnosed when I was in mid-30s and after my third child, and I didn't really worry about it because my dad had polycystic kidney disease, and because of his generation, they never talked about it. Mom and dad would just, sit around the table and just pretend that dad was okay. However, his tummy was the size of carrying twins because the size of his kidneys. And I knew because of his progression of the disease that I would eventually need a transplant in my early 60s. The same thing happened with my two uncles, and my aunt was fortunate enough not to have a kidney transplant. So as my kidney grew, my body changed. I became depressed. It was difficult for the family to understand the disease that I had because of the way I was brought up. I didn't really talk about it. And then I finally got to the point where I had to talk about it because it was affecting my thought process. I was getting a bit of brain fog. And I figured it's not going to hurt for people to know this is what is happening inside of me. I decided to just tell the world, I've got a big belly because I have these big cysts, and sometimes I'm not with it, and these are the reasons why. And I told anybody who asked the question. And for me, I think that was the biggest gift, I'm going to get emotional, I gave myself and my family. So as the disease progressed, the clock was ticking. And between the ages of 55 and 60, my kidney function went down from like a 37 to a 35 to a 30, and it was just going down, down, down. I was then moved at that point in time. I was under the care of Dr. Pei, who was doing research for polycystic kidney disease. And I had been with him for over a decade. And it was very difficult to transition from a physician that had taken care of you for over a decade into a team that you didn't know. You didn't know who they were. The relationship wasn't there. But trusting the system and knowing that I would be taken care of, I just sort of moved forward. So when I, really mentioned to my friends and people that have asked, how are you doing, Janet? I would say, well, it's time. I really need to have that kidney transplant. I think because I talked about it and shared my thoughts, my condition, my worries, I was so blessed. I had so many people step up and filled out that very simple form to see if they could be a donor. So it was family, it was friends, acquaintances even said, tell me what to do, Janet. I will donate the kidney, because they were aware that some people are just born with one kidney and they live very, very healthy lives. We don't need two kidneys to live a normal, healthy life. So my friends and family, they all put in their applications, and it was a frustrating time for me because I was on the other end. The form was submitted, and it would take a period of time for the transplant team to determine if this person was eligible for donating a kidney to me. The first person who was rejected was my brother, who we thought he would have been a shoo-in, but he had a medical condition that was identified through the testing because he was the first one being processed. And then another friend went through the same process, and for reasons that transplant or process did not proceed. And so as this process was going through, all I was saying is this: my kidney function is going down. It was like a 25, 20. Now it was kind of hovering at a 50. And I was just blessed that a girlfriend gave me the phone call. And she said, I am eligible to give you a kidney. So in amongst all of that, I was becoming a nervous Nelly. It took me a while to understand the internal process of what the hospital was dealing with in terms of the number of applicants that were being processed. So think of thousands of pieces of paper and hundreds of people waiting for a transplant, and the triage and how they managed in the back end. I eventually understood, but at the beginning of the process, I did not understand it. And I was a bit frustrated and I was worried. I was afraid that I was lost somewhere within the hospital. But lo and behold, I got the green light, and my girlfriend Jane went through a lot of testing. So that was myself and my donor being Jane. But behind every family is a team, and all of us stuck together. There was communication between our family and Jane Garrett's family. Jane made sure that her family was comfortable with her giving a kidney because neither one of her children had babies at that point in time. So it was a very big decision from her family perspective. On my side, it was just incompatibility. And so it just worked out. So this is the team that supported our family, and I just wanted to acknowledge them. So the kidney transplant was arranged for 2019 in August of 2019. So here I am, the morning of going into surgery. I had no fear because I knew I was in the best hospital with the best physicians. And at that point, I was well versed and educated by the transplant team. So that was the day before, and the next slide shows me the day after the transplant. And sitting up and just so healthy, and the kidney worked right away, and I was just blessed. So it's been 3 years. I'm skiing, I'm golfing. The donation of a preemptive transplant just eliminated me having to be on dialysis and hooked up to a machine. Jane is doing amazingly well, no medical issues, healthy. And I just encourage everybody to do the research, ask the questions. And if you're waiting for a transplant, just talk to people about it and don't be afraid to share your fears and your concerns. And this is my donor. And I love you dearly, Jane. Okay, and that's a little bit of my story. Anyways, that's my story. And people like Michael was at the back end trying to figure out how these person like myself helped me to navigate and Jane navigate through the process. And I passed it over to Michael because he had a lot of heavy lifting to do.
Thank you so much, Janet. We really appreciate hearing your story and hearing about you and Jane and the process that you went through. to find a living donor, because we know a lot of people have questions about that. And I'm sure we'll have a lot of questions from people after Michael's presentation as well, but we're really grateful that you will be willing to share your journey and your gratitude to your donor. And we're especially grateful to Jane as well, because of all of the amazing things that you're able to do now post-transplant. So thank you so much for sharing your story and for being here today. And now I'd like to pass it over to Michael, who's going to present from the medical side of our team, from the kidney transplant program perspective of a preemptive transplant. So welcome, Michael. Thank you so much for being here today. We really appreciate it.
No problem. Thank you, Candace. And Janet, thanks for sharing your story. It's always nice to hear these stories after the fact, because once you get to transplant, usually the pre-transplant office gets kind of left out because we don't follow you anymore after transplant. So we forget sometimes just what an incredible impact it has on people. So thanks for sharing that. I will try and go through this relatively quickly. So I'm just going to take you through a little bit of the logistics around the kidney transplant program, what it's like when you have a living donor, sort of the process of getting yourself referred for transplant, getting your donor involved. We'll talk a little bit about how kidneys work, but I won't spend a lot of time on that. We'll touch on the different types of transplants, and we'll try and focus mostly on the power of preemptive transplants and why this is such an important area that we're really trying to expand as an opportunity for people. All right. So you can see there's kind of two pathways. There's a recipient pathway and there's a donor pathway. So the referral is always the first step. So for a recipient, and if you're preemptive, you're either in a multi-care kidney clinic or you have a community nephrologist that's following. And when your GFR gets to about 20 or so, that's really when we want you to be considered having a referral if you have a potential for with a living donor. You don't need the donor cleared at that point, but you should have somebody identified. So it's something that, as Janet pointed out, if you start talking about it well in advance of that, that's when people can kind of start formulating. It is not an easy decision for a lot of donors to make, or it's very hard for them to make if they don't know that there's an issue there. And it is very, very common, as Candace said, for people to have difficult time making this ask and talking about it, sharing your health. There's so much talk about privacy and protecting your privacy. It's almost counterintuitive that in this case, breaching your own privacy is kind of necessary to take that next step. But there are two separate teams. There's a recipient team and a donor team. The recipient team will take you through that referral, the evaluation, and then listing or being cleared for transplant is kind of what we're doing. And with preemptive transplant, what we're really trying to eliminate is that blue box, that waiting period, that time between when you're cleared for transplant and when we actually do the transplant. And we'll talk a little bit about that at the end. The donor needs to go through that whole process as well, and it's important that they're coordinated. So we have lots of times where a donor will come forward before a recipient is referred, and we have no idea who this donor is talking about because we don't have the recipient yet on our roster. So it's important to make sure that as a recipient, you get your referral sent in, and then you ask your donors to submit their paperwork and things like that. It makes the process a lot more coordinated and smooth with following through that. But the teams are separate, and for very good reason. We always want to make sure that the donor has an opportunity to be evaluated without any sort of impact or influence from the recipient side. So the donor team is really only concerned about the donor's health outcome and whether or not it's safe for them to be a donor, and they'll have those specific questions and discussions with the donor. Your kidneys do a lot of different things. They filter waste products, they help you manage your blood pressure. There are all kinds of electrolyte balances that your kidneys do, and it's all you don't have to think about these are all automatic things. One of the things that you'll see as kidneys fail, you start retaining fluid. There's lots of changes. As Janet pointed out, you just feel differently, and lots of people, because it happens usually over a period of time, you don't always necessarily recognize how bad you're feeling. So we hear quite often after transplant, I got my kidney, I didn't realize how bad I felt beforehand. So even though you've gone through a surgery, if the kidney's working right away, you actually wake up feeling a lot better. You have a pain in your side, but you do feel better. All right. And with preemptive transplant, we can avoid, dialysis is something that's absolutely necessary, especially if you have to go on the deceased donor waiting list for the most part. But it does have risks. There are procedures you need to go through no matter what type. So whether it's a central line, whether it's a fistula or a graft that needs to be placed for hemodialysis, or a peritoneal catheter for peritoneal. It is not without risk. And the longer you are on dialysis, we actually start to see a decline in how much benefit you get from the transplant in terms of longevity. So one of the things we talk about when we talk about the benefits of transplant is, compared to people on dialysis, you tend to live longer when you get a transplant versus staying on dialysis. So that's one of the reasons why we do this. So as your kidneys fail, it takes a progression, and it happens over time. There are some times where you have what's called acute kidney failure, where something, there's an injury or, a very severe infection that, might knock out your kidney right away. Or, some people, if they have an anoxic injury, so a lack of oxygen to your kidney. So one of the things that, if somebody has a cardiac arrest or something like that, there's an acute injury to the kidney and it might not. But a lot of other diseases like Janet's disease, it happens over years and years and years. So you'll go from, a stage 3 to a stage 4, eventually to a stage 5 of your kidney failure. And then eventually you'll need renal replacement therapy, whether that be dialysis or a kidney transplant. And if we can get you a kidney transplants, have lots of health benefits. Living donor transplants have the most health benefits. And out of the living donor transplants, we maximize all the benefits by doing it preemptively. So if you get through the evaluation as a donor, everybody goes on the deceased donor waiting list. But if you have a living donor that we're evaluating, we'll usually keep you on hold until we have exhausted all possibilities of living donor transplant. And the reason for that is you continue to gain your allocation points, so you don't lose your place on there's no downside to being actively on the deceased donor waiting list, but not actively listed. The advantage of getting a living donor transplant is those kidneys tend to work better right away. So most of the time those go in and start working, as opposed to deceased donor transplant, where 30 to 40% of those times the kidneys don't like the whole process of being donated and transplanted. They get a bit of shocked and swollen, and it takes either a few days or even a few weeks for the kidney function to pick up. So from that perspective, living donor kidney transplants work better. Living donor transplants also tend to work for a much longer period of time, in the magnitude of many years longer than deceased donor transplants. And it doesn't have to be someone related to you. As Janet pointed out, she had family members that were assessed, and then it was eventually a friend that donated to her. So we look at a whole bunch of different factors for compatibility. So does a recipient have antibodies to a particular donor? Are they blood type compatible or incompatible? So just because somebody's a different blood type doesn't mean they donate either directly to you. So, somebody whose blood group AB as a recipient can get from any blood group donor. So you don't have to screen based on that. There is an incompatibility issue, then we can always look at the paired exchange program as well. And living donors really make preemptive transplant a much greater possibility. We'll talk a little bit about at the end about how you can get on the deceased donor list as a preemptive recipient. But for the most part, the only practical way to get a kidney transplant pre-dialysis is through living donation. So these are just some of the basic criteria for being a donor. So anybody that's interested, we want them to be healthy, older than 18. They have to be willing to donate. And that's something that can be a challenge sometimes is, people may say, oh, okay, yeah, I'll be a donor, especially if, somebody's putting a little bit of pressure on them to submit their things, and then they never do their testing, or, they're really not, it's not something that they're really willing to do. Or once they learn about the risks, it is not a little ask. This is a surgery that the donor doesn't necessarily need for them. They're doing it on behalf of the recipient. So it's important that they're supported. And that's one of the reasons why the recipient team and the donor team are separate. All right. They have to contact the donor office, or they can go online and get the health history form, and they submit that health history form, and then the donor team will take them through the evaluation if they qualify. All right, so there's blood tests, there are scans, so CT scans, sometimes heart tests, other things. If there are issues identified within the donor evaluation, they may need, something like, if they notice there might be some fatty liver, they might need a hepatology consult. That's a liver doctor consult or things like that. So the donor team takes care of all that. And on the recipient side, we basically get told whether or not a particular recipient has a donor evaluation, or whether that evaluation is completed and they're either medically suitable or unsuitable. There's very limited information and sharing that goes on from that perspective. If there are circumstances that do require discussion, then obviously the donor team will identify those, and we will discuss those as a team. Okay. Candace, with the Center for Living Donation, this has been a great resource. So these webinars, talking to people about the different aspects of donation and providing support to people as they journey down that, because it's not unusual. So we're looking at healthy individuals. So lots of times donors have had very little impact or very little interaction with the healthcare world. So it's a very new experience for them. And so we want to make sure that we have people supporting them. The Donor Championship program, lots of people have lots of different questions about donation and the impacts, the long-term thing. So having a support like this has been incredible for donors. So here we go, just in terms of some of the statistics. So over 96% of the time at 1 year, a living donor transplant is in and working, and over 86% of time after 5 years, they're working. And 15 years plus is sort of the 50% half-life. So most kidneys live or last more than 15 years in terms of living donation. Compared to deceased donation, we're 2% difference at 1 year, even greater at 5 years. And, the half-life is closer to about 10 years with a deceased donor kidney transplant. So significant difference in terms of how long kidneys work. But all transplants, comparatively speaking, are very successful. So it is, we've been doing it for a long time now, and living donation, deceased donation, the surgeries and the outcomes are very, very good over time. It used to be you didn't really talk much about anything other than 5-year survival rates, but that's, the vast majority of people get to that point, and you're looking at 10, 15 and beyond now with in terms of outcomes. So hard to match, this is what we talked about. So some people, if they've had a previous transplant before, you can get a second, third, even fourth transplant. If you've had a lot of blood transfusions, or for women that have been pregnant, you've potentially been exposed to other DNA through those events. So pregnancy through the placenta and the exposure to the fetal alcohol, because half the fetus tissue typing comes from the mom and half comes from the dad. So that's one way. Blood transfusions, we give you somebody else's blood, so there's different DNA. It's not, it may be blood group compatible, but it is not at a DNA level the exact same. And then transplants as well. So you develop antibodies to other tissue typing. The more antibodies you have, you get a PRA, and it gives us a percentage. So that 95% means if we have 100 blood type compatible donors, 95 of them you have antibodies to, and 5 of them are a potential match. That can go all the way up to 100%. So the higher that number is, the more difficult it is to match you. All right. So then we need to look at, is this particular donor blood type compatible? Are they tissue typing compatible? And if they're not, then we talk about the paired exchange program. Or some people may go on to what we call a highly sensitized patient program. And, at that point, this is another area where we would look at, even if you're not on dialysis yet, because you are given priority within this program, we would look to put you on the list at that point in time. And you can go on that list even if you have a living donor. We can also explore either paired exchange opportunities or direct donation opportunities. But with a living donor, if you're compatible, we're looking at direct living donor transplant. Incompatible, the other option is doing something through the kidney pair donation program. So this is a national program. We have put you into this program. So whether it's a blood type incompatibility or an antibody incompatibility, we can go in, and this has been a very successful program. So it started in 2009. I think we're well over 1,000 transplants nationally through this program. So these are all transplants that prior to that, only a very small fraction of them might have happened because only a few programs did this across the country. So it is another area. And again, with a preemptive transplant, getting you cleared, ready, having your donor cleared and ready, and going into this program, because it may take several months or even a year or more to find a match and get actually to transplant. So it can be challenging if you're, on a preemptive and your kidney function is declining quickly, whether or not we actually get you to transplant beforehand. But with preemptive transplants, even if you're only on dialysis for a short period of time, you still get most of the benefit in terms of long-term longevity and things like that. And hopefully we can make that window of opportunity and get you transplanted before you need any of that. So the benefits of transplant, so no more dialysis or avoiding dialysis completely, feeling better, being healthier. Most people with transplants compared to on dialysis, you have fewer hospitalizations, you tend to be healthier overall, fewer limits on what you can eat and drink, you're far more independent, you can be traveling, you can do these, you can go back to work if you're not working, all those types of things. And you too tend to live longer than people on dialysis. All right. Some of the downsides of transplants: everybody will need to take anti-rejection medication. You'll be on these medications for as long as this kidney is in and working. You may even be on them after the kidney stops working, but if the kidney is still, if it hasn't been removed, and we usually try not to have that surgery happen, you will still require some anti-rejection medications. They definitely have side effects. So things like blood sugar control issues, increased risk of infection, increased risk of cancers, bone disease, those types of things. And the transplant team will talk to you about that. And it's different for everybody in terms of what your actual risk profile is. There's, depending on the type of illness, there's also a chance of potential recurrence of the kidney disease in the transplanted kidney, but it's not always the case. And again, that's a very specific case-by-case discussion. All right. Transplants are not a cure for what caused the kidney failure, but it is the best treatment option for it. Okay. And not everybody, but the vast majority of people do qualify for kidney transplantation. So, if there are specific reasons why you can't be a candidate, the medical team would discuss that with you. So like we talked about before, the first step is really the referral. You get registered here, your case is reviewed. If you have the potential for a living donor, hopefully they come forward at that point in time. There's always some tests that your referring center, whether it's your nephrologist or a clinic, they'll send ultrasound, chest x-ray, some cardiac testing, your usual labs that you do when you're on dialysis. And then we ask for some serology or virology testing. So things like MB and EBV, HIV, hepatitis B and C, those types of things. So they send us an entire package, cancer screening tests. We'll review those. Then you'll come and see the team. You'll have a meeting with one of the assessment coordinators. We'll do some education with you around transplant, around the evaluation. Then you'll come and see the nephrologist as well. They'll do a medical review. They'll identify any areas where we may need some more information. So if one of your heart tests was abnormal, we may say, we need a cardiology consult, those types of things. So all that has to happen. And then you'll come and see with one of our social workers who will take you through the requirements for transportation, make sure you have enough family supports in place. As Janet pointed out, it's not a one person, it affects the whole family and everybody around you. And we want to make sure that everything's in place. So drug coverage, transportation plans, all those types of things. And the social worker will go over a lot of that. You'll see one of the anesthesiologists and the surgeon. All right. And that's kind of the basic workup. And if you have a living donor, we just kind of go through that process, and we'll take you through it as quickly as we can. Just recognizing that right now, specifically, there's close to 1,000 people in evaluation, so it doesn't always happen as quickly as you would like, but we do try and get it done as quickly as is possible. So we talked about a lot of these, so heart tests, blood tests, imaging. There may be some specific tests that we need to do based on your health history. There may be a specific, surgeon that we send you to. So, in Janet's case with somebody with polycystic kidney disease, we need to make sure that there's enough room to actually put the kidney in. So we often refer to one of our surgeons early, and they'll assess to make sure that the transplant can actually happen. People with a history of vascular disease. So if you've had diabetes for a long period of time, or other, diseases that are prone to vascular or hardening of the arteries, our surgeons may ask for a CT scan or something like that to make sure that they actually have a place where they can put the kidney. All right. So medically you may be suitable, but we also need to make sure you're surgically suitable to receive a kidney transplant. Once you're sort of through that evaluation process, we have all the information we need. There's always a listing meeting. So the team, which is transplant nephrologists, transplant surgeons, social workers, transplant nurses. We have an ethicist that usually attends these meetings, plus our fellows and residents that are involved. We will discuss your specific case. So it's presented to the team. If there are particular items that we need more information on, we may need to get those. But once we review all your tests and assessment, if everything's in place, they'll either approve you for transplant, or we may need additional information, or in some circumstances we may say that as a team we've decided that transplant is not in your best interest, and in those cases you'd be offered a second opinion. You could go to one of the other transplant programs in Ontario, so Hamilton, London, St. Michael's here in Toronto, those types of things. But otherwise, if you're cleared, we put you on the transplant waiting list. And if you have a living donor in evaluation, you'll be on hold until we figure out whether or not that donor is going to be cleared. And if you have multiple donors, if we don't clear the first one, then they'll do an evaluation on a subsequent donor at that point. If you're preemptive and you're cleared for transplant, if your kidney failure is advanced enough, then that's when we're going to talk about potential for transplantation. If your donor is cleared, then and there's no matching issues, we don't need anything like the paired exchange program we talked about, that's when we can really schedule a surgical date. All right. Depends a little bit on how much flexibility you have as well as your donor has in terms of the timing. So like right now, we're pretty much booked through the end of November, and we're starting to book transplants into December, but people can go on what's called a backup list. So if you had flexibility, you could go very quickly. Within a week or two of being notified, you could be on that backup list. So if somebody got canceled, which we're seeing unfortunately still with COVID, cases get canceled at the last minute, because you usually need at least 4 weeks from a COVID diagnosis to being able to be transplanted right now. So we have people that are all ready to go, and then we find out, a week, 10 days before their surgery date that they just tested positive. Now they have to wait for 4 or 6 weeks until things are cleared up. So that's an option, And generally speaking, what we do is we usually talk to the donor first about when they might be available. We'll talk to them about available dates, and then we coordinate from there. All right. But sometimes, especially with preemptive patients, you may be too early for transplant. So we may have, had a referral and your GFR was 20 and it had been declining steadily to that point, but it kind of plateaus there and you're not having any symptoms. So we've got you cleared, we've got your donor cleared, but it's just too early for transplant. And in those cases, we'll evaluate every 3 to 6 months. And of course, if things change, you can contact the office, or your nephrology team can contact the donor office or the transplant office and say, what, things look like they're starting to progress. And, we should relook at booking the surgery. So that does happen. All right. And sometimes we clear a recipient, but the donor's not yet cleared to proceed. So again, that delays that whole thing. And sometimes, that can impact. So if you're ready to go as a recipient, but the donor issues are such, or we have to restart and book look at a new donor. You might be ready to go, but if it's getting close, now your GFR is 8 and you're starting to have symptoms, sometimes you might need to go on dialysis for a short period of time afterwards. Or something happens quickly. We have everybody cleared, you're too early, you get an infection of some sort, and that's enough to tip you over the edge. You start having a lot of uremic symptoms. You're not doing yourself any favors not doing dialysis if you need dialysis. So coming into transplant really sick and not doing well is not something that we really recommend as well. And it's really a whole team effort between yourself, the transplant team, your nephrology team, having those conversations and figuring out what's best for you. So we do try as much as we can. It's not always guaranteed that just because you're cleared as a recipient that we're going to be able to do your transplant prior to dialysis. But absolutely, we try and get that done. All right. The other part there, we've talked a bit about the kidney pair donation program. So if there's an incompatibility issue, whether or not we get a match soon enough, and a match through the paired exchange program, about 30 to 40% of the time, those matches don't end up resulting in a transplant, because it's not just the match to you, but there could be 4 or 5, 6 other recipients that are all involved. And if one part of the matching doesn't work, the whole chain of matches doesn't work, and we're not able to proceed at that point. All right. The next slide. So there's just demonstrating that the surgery. So generally speaking, we don't touch your kidneys unless, in the case sometimes of polycystic kidney disease, we would have to remove one of the kidneys or both of the kidneys to make room for the transplanted kidney. And generally speaking, we would want to do that before the transplant surgery itself, because that tends to be a big surgery in its own. But as long as there's enough room and there's no other reason for doing this, generally we're going to want to leave your kidneys, because if you're not on dialysis, they are still functioning at a certain amount, and having more kidney function is better than having less kidney function. So we put the transplanted kidney in on top. And you can see down there in that picture that the kidney goes in, and we actually attach it to what are called your iliac blood vessels. All right, so the iliac blood vessels come off of your aorta or your vena cava and go down into your leg area. The other reason we put it down there is it's nice and close to your bladder, so we don't need a long ureter to connect the kidney to the bladder. And everybody, when we do a living donor transplant or a deceased donor transplant, gets something called a stent put in. A stent is a small rubber tube that goes from your bladder up through the transplanted ureter, which is the tube that connects the kidney to the bladder, up into the kidney, so that can heal into place without getting blocked or kinked. The picture there is of a stone that's blocking a ureter, and that doesn't usually happen with transplant, but that's another reason you'd use a stent. So it allows that urine to flow from the kidney into the bladder without any restrictions, so that it can all heal into place. Right? And that usually comes out about 3 to 6 weeks after the transplant. Next slide. So that kind of takes you through the process. The one thing I didn't touch on is if you don't have a living donor and you've gone through this, or you're through the process, and then at the last minute we find out that your donor is not suitable, you can go on to the deceased donor waiting list and be active on the deceased donor waiting list, as long as your GFR is less than 15 on at least 2 occasions. All right. The practical value of that, if your blood group O or B, is very limited, because the waiting times are usually somewhere between 5 and 8 years, depending on the extended or older donor programs or the standard criteria. So right now, you're usually waiting about 7 years for a blood group B or a blood group O kidney transplant from the point you wait on dialysis. So if you have not started on dialysis, you're not getting any dialysis wait time points. The only time we would, that there is some advantage to that is if you, like I said, if you're on that highly sensitized patient program, you're hard to match, then you would go on the list at that point in time. The other time is A, and especially if you're an older recipient, the extended criteria list is usually very small. So, in that case, there are, we would consider putting you on, and there's a chance you would get a transplant. Same for AB, that list tends to be short. and you can get a deceased donor transplant, even though you're not yet on dialysis. And that has certainly happened.
Amazing. Thank you both so much for all of that information. It was fantastic to hear from both sides of the coin. As I'm listening to this presentation, Michael, I'm wondering, I have a question about this preemptive journey, and I know this is difficult to answer, but it's a question that I hear all the time, is when is the best time to get a preemptive transplant? Is there like a number? Is there, we know that we don't want to be too sick, like you said. So how do we know when that time would be as patients to ask for a preemptive transplant or to find a donor?
Yeah, so it's definitely a challenging question. There's no one answer to that. So it really depends on your journey. So how quickly is your kidney function declining? Mm-hmm. In general, we usually, if your GFR starts to hit close to the 20 mark, that's probably the time, because it always takes a bit of time to get your testing up to date, the referral to be made, and then us to assess things. But if you're really starting to see that your function, you're at 30 and you were at 40, 6 weeks ago, and things look like they're progressing quickly, then that's also a reasonable time to have that. So that's a conversation as your kidneys are failing to have with your nephrologist to make sure that it happens early enough. We have had cases where somebody gets referred to us and their GFR is 10, and it's been a pretty rapid, and there's just not enough time to get everything into place. So right. Probably better to err a little bit on the side of caution. So 2025 is probably fine, because the other thing that we can do is we can evaluate you as a recipient, get you all cleared and ready to go, get your donor all cleared and ready to go, and then if we have to wait a period of time, then that's fine, right? Better to be ready to go. You may need to repeat, and that's the other thing that we run into sometimes. We're all ready to go, everybody's cleared, but if it's not the right time to do the transplant because you're too well, that's an okay situation, right? Maintain your own kidney function for as long as you possibly can. Work with your MCKC teams, your nephrology teams to maintain that. We'd rather have you sit and wait because you don't need a transplant than transplant you too soon. All right.
Amazing. Thank you. And Janet, I know you talked a little bit about sharing your story and how people around you knew that you were going through this process. I'm wondering if you can tell us a little bit about, what did you tell them? How did you share that? And, it's a difficult thing to go through, to be vulnerable and tell people about your health journey. I'm wondering if there was anything that, people around you did that helped you through this process to tell your story. Did you have any advocates or things that you said to help people know what you were going through?
Yeah, because I had the disease for so long, right? Over 30 years. It was more in the last 10 to 15 years that I really reached out to people to tell them about my story. Because I was suffering, I had depression. I wasn't thinking properly. And other people would see that in me, but I didn't see it in myself. So to what Michael was saying or alluded to, you really don't know how sick you are. But people outside in, they see you, wow, you're changing, but you don't think you have changed. So because of the physical change and the change in my cognitive ability, people would ask me questions because they knew that I had polycystic kidney disease. So when they asked the question, I was so grateful that they asked the question, because then I could tell them, yes, I'm feeling sad. I'm not thinking properly. I am sick. I know when I hit the 60s, I will need a transplant or to go on dialysis. And, through the family and the network, friends and family reached out to other people to say, my sister or my aunt or, a friend of mine needs a kidney transplant. So, for an example, my brother who wasn't eligible, like he was telling his story and how sad he was. He couldn't be my champion. And that emotional impact him was huge. So he reached out to his network in Edmonton, and people in Edmonton were saying, okay, well, your sister needs some help, so let me figure this out. The best gift you can give yourself is to share your story. And there's nothing, in my opinion, to be shameful of being sad, being looking like a blowfish, like even my fingernails were puffy. And then people understand better what they can or cannot do. And some people say, well, I'm not doing this. I'm afraid to donate a kidney, but I might know somebody. So I just think talking about it, but the journey it was scary. Like when I was hitting the 20 GFR, EGFR, and there was one person, my girlfriend, in that process. I'm just saying, hurry up, get these tests done. And then finally, she was my advocate, and she went to the transplant team and said, well, I have to have this done because my son's getting married, and I want the transplant done by the end of August. So she became my advocate. Also, my health was just going way, way down. I was around the 10, 15 mark. So does that answer your question?
That's fantastic. Thank you, Janet. And I think one thing that you said there too that's really important for people to hear is that the donors who step forward are doing so because they desperately want to. And like you said, we often have donors who are not eligible to donate, who are really upset that they're not able to. So know that the people who are coming forward are doing this because they want to. It's a rigorous process, as Michael spoke about. So, safety is the utmost importance for us when the donors go through this process.
Mhm.
And so if you have somebody who steps forward who is interested to be your donor, please allow them to look into this and make that decision on their own. So, Michael, I'm wondering if we can ask you to have any final thoughts about preemptive transplants and the journey. We had a question from somebody who asked, how do they deal with the feeling of guilt that they might not be deserving, or why are they getting the transplant over someone else?
It's a good question, Candace. And I think the answer is, every time we do a living donor transplant, we are freeing up an opportunity for somebody else to get a deceased donor transplant. So while that's a definite benefit. The other thing that we have to remember is the demand for dialysis is ever increasing right now. And if we can keep somebody off of dialysis, it's freeing up those dialysis spaces for somebody who does not have a potential for a living donor. So that's another impact that it has. The other thing, anytime we can prevent somebody from having to have an access created, so something like a central line or a vascular procedure, that's freeing up those resources for people that may not even have kidney disease but may need interventional radiology or a vascular surgery procedure. So it's freeing up resources for those types of people as well. So everybody deserves a transplant. And if you have the opportunity, I can understand why somebody would say, why me? But why not you as well is another good question, because everybody deserves it. And if we could transplant everybody preemptively, we would. But don't apologize for having a donor. We'll take you through that, and we'll support you through that process.
Amazing. Thank you so much.
Okay.
And Janet, I'm wondering if you have any final remarks that you would like to add for patients and potential donors or family members as they're going through this process.
It's important to ask questions. And if you don't know what question to ask, just try and find a way of getting those words out. Because when you're talking to your team, your friends, your family, it's difficult sometimes to paraphrase and say, this is how I feel, or this is what I need to know. So use your system, your family, your friends, to be your advocate as well, and just ask questions. And yeah, my biggest regret was I did not talk about the paired program enough. The benefit of the paired program is huge, and it saves and helps so many people. And during the journey that I went through, I didn't know enough about it, and that was because I didn't know how to ask the questions. So that would be my advice.
Wonderful. Thank you both. Thank you so much. We really appreciate having both of you on, and thank you so much for the incredible information that you've shared today.
Thanks.